Today I'm joined by Obstetrician and Gynaecologist Dr Kelly Hankins for an important episode in honour of Endometriosis Awareness Month, which we recognise in March. Endometriosis affects 1 in 7 women, which is up to 14% of the population. But how do you know if you have it? What are the causes and treatments? Kelly is cherished by her patients and is a wealth of knowledge on women's healthcare. Join us as we take a deep dive into endometriosis, vaginismus, hysterectomies, cervical screening, female anatomy, and so much more. Let's get into it. So Kelly, it's so lovely to finally meet you face to face. Thank you for giving your time up to come and talk to us.
Yeah, thank you for having me. I've been really excited about my first podcast.
Sorry, it's going to be cool. Okay, so endometriosis, everybody's talking about it. It's finally kind of got out there, and people seem to be a bit more educated about it,
yes,
especially people who have it. But can you tell us, what on earth is it?
Yeah, so it's a really good and a very timely topic, I think, because we're right in the middle of Endometriosis Awareness Month at the moment. So endometriosis is an incredibly common disorder that I think has been overlooked for many, many years, or I guess not as understood as it should be. So it affects up to 1 in 7 women, or people assigned female at birth. So up to 14% of people. And what it is it's an inflammatory condition where cells that are very similar to the lining of the uterus are found other places in the body. So this can commonly be in the pelvis, so involving the ovaries, involving the pelvic lining behind the ovaries, the space behind the uterus, the bladder, the bowel, that type of thing. Occasionally it can be found like in a cesarean scar or in scars from other reproductive surgeries, and it can even be found in distant organs such as the lungs. But what happens with endometriosis is you get these little implants of tissue that respond to hormone changes throughout the menstrual cycle. And so these implants become inflamed, they can bleed, and then over time that causes scarring and a lot of pain in the pelvis.
Okay. So how would someone know that they might have endometriosis?
So it's a really variable disease. So women with a small amount of disease can have a lot of pain. Women with really advanced disease might not have much pain at all, and they might not even know they have endometriosis until they have trouble conceiving. But very common symptoms that I see are things like pain with periods. So often pain that will precede menstruation by a few days to a week. And that pain can be pelvic in nature. It can be in the lower back. It can be in the legs. Some women get bloating. They get changes to their bowel habits. So pain when they pass a bowel motion, occasionally blood in the stool. They can have what we call Dyspareunia, which is painful intercourse. They can have pain when the bladder is really full, or symptoms of bladder irritability, like urinary frequency, pain with urination. They can also have other systemic symptoms during their period. So they can have nausea, vomiting, severe fatigue, aches, headaches, heaps of things that just make them feel generally unwell. I get a lot of women coming to me with these symptoms being brushed off and saying, people have told them it's not that bad, it's just part of a period, but those symptoms are not normal in a period.
And so I know that I'm sort of slightly moving sideways, but how much pain is normal?
Yep.
In a period, and when is it beyond what you would consider within the realms of normal?
Yeah, so I would say period pain that is quote unquote normal would be pain that's maybe a bit of pelvic cramping that's the first day or two of a period, and it's generally relieved by an anti-inflammatory or Panadol, and is not enough to interfere with a woman's day-to-day activity. The pain needs investigation when it's not relieved by simple analgesia and when it's disruptive to a woman's life. So it's affecting her quality of life, and it's affecting her school, studies, work, social life, relationship, that type of thing.
Okay. And so what does it mean when you have endometriosis? So you might have these little bits of tissue in various organs in your body. Does it ever just spontaneously get better, or is it something that just keeps getting worse?
So again, it's a really variable course, and we in the medical field are still learning a lot about what we call this natural history of endometriosis. So we do know that the disease can get a little bit better with pregnancy, right? So the shift in hormones can cause some of that disease to become inactive, but it often doesn't go away completely and then can come back years down the road. Other women, the disease is quite active in adolescence and then stabilizes. And in other women, it tends to get worse as they get closer to menopause. So it's highly variable.
Okay. And obviously lots of women get really concerned about having endometriosis and their fertility.
Mm-hmm.
So what actually is the mechanism that it's impacting fertility?
Yeah, so women with endometriosis can have trouble conceiving. I think it's important to stress that the vast majority of women with endometriosis can go on to have a baby, often spontaneously. But there are a couple of ways in which endo can affect fertility. So one of those ways is that you can get inflammation in the pelvis from the disease itself. And so that inflammation can affect the function of the ovaries in terms of ovulation. It can affect tubal motility. And so the egg can have a difficult time moving down the tube to meet the sperm. And it can affect the uterine lining and make it less receptive to implantation. So that type of, that effect on fertility can be improved with surgical excision of endometriosis because it can quiet down the inflammation in the pelvis. The other way in which endometriosis can cause infertility is by actually distorting the anatomy and by causing scarring or blockage of the fallopian tubes or ovaries. And so when that's the case, that's generally irreversible. And those women will then go on to need IVF to conceive.
Okay. And is this something that sometimes you discover maybe doing a laparoscopy because someone's struggling with fertility and they maybe didn't know?
Yes, yeah, exactly. So when I am evaluating a patient for infertility, if there is a suspicion that they have endometriosis, and if there's a suspicion it's not too advanced, then I would offer them a laparoscopic evaluation. And so during that surgery, my aim would be to treat any disease that they have by removing it. My aim would be to try to restore their normal anatomy as much as possible, and then also test the fallopian tubes to make sure they're open. And we do that with a little procedure where we basically infuse blue dye and we watch it spill out the ends.
Right, okay. And in terms of whenever you say remove it, are you cutting bits of tissue away or are you burning it or what are you doing?
Yeah, so there's two different ways to treat endometriosis surgically. You can do what you call an ablation, which is where we use heat to burn the abnormal tissue away. I think the general thought in the gynecology community is that excisional treatment is going to give a better result. And so with that surgery, what I do is I remove the pelvic lining all around the deposits that I can see. So I remove the deposits and remove any associated scarring over the pelvic organs. So that often involves sort of peeling the tissue away from the underlying organs like the bladder, the bowel, the ureters, that type of thing.
Okay. And do we know why? Is this something that people have from birth and then it appears when they start menstruating? Or do we know why people have endometriosis?
So I think it's not known for certain. The leading theory with regards to how women develop endometriosis is we think that it's caused by retrograde menstruation. And what that means is that when a woman has a period, most of the blood exits the body vaginally, but a small part of it will flow backwards through the fallopian tubes. And then in some women, that can implant in the pelvis. And those women may have a little bit of a genetic susceptibility to that. When that blood goes back and implants in the pelvis, it causes an inflammatory reaction. Your body attacks it a bit like an infection, and women get those unwell, that nausea, the aches, that type of thing. We know there's a familial predisposition to it. So women who have a close family member, sister, mom with endometriosis are about 7 times more likely to have the disease. But we don't know the exact genetics.
And so my brain's trying to work out how you would get a bit of that to go to your lung, for example, because I've had a patient who had endometriosis in their lung. Yeah, that seems so crazy. So how on earth would it have got to their lung? Do we know?
So it must not. It must not completely be the retrograde theory, right? It may spread a little bit in the blood or in the lymphatic systems, that type of thing. It's hard to say. There's a lot we don't know.
It seems crazy. Okay, and then a lot of my endo patients also have a thing called adenomyosis. So can you Because that can be a bit hard to get your brain around what that is.
Yep. So adenomyosis is a condition related to endometriosis. It's sort of in the same groupings, but the pathology of it is a little bit different. So what we think happens with adenomyosis is we think that the lining of the uterus grows into the muscle layer a little bit. And so the uterus becomes inflamed and angry, right? It's swollen, it's a little bit bulky. And those women can also have pain with periods and heavy menstrual bleeding.
Okay. And does that have an impact on fertility?
It can as well, although many women with adenomyosis can still go on to conceive. Adenomyosis can occur in any age group, but it's more common in women who have had children.
Right, okay. And so apart from having surgery, if someone is listening and they've got endo, what are their treatment options?
Yeah, so we often would start, treatment is aimed at pain relief, right? Treatment is aimed at trying to make the disease a little bit more inactive with a goal to restore a woman's quality of life and preserve her fertility, right? So we would often offer some sort of pain relief, some sort of anti-inflammatory. A woman may respond well to one anti-inflammatory and not another, right? So it's worthwhile trialing a few to see if those work. And then we often do hormonal treatment because the idea with hormones is that we provide a steady level of hormone to the body to prevent the fluctuations that can affect endometriosis and worsen the symptoms. So hormones can be given in all sorts of different ways. So there's the birth control pill, which is probably the most common medicine women start on. There are progesterone-only pills. There are injections, implants, and then the Mirena IUD is a little progesterone implant in the uterus that's become quite common for treatment of endometriosis.
And quite successful?
Quite successful. With hormones, there's no one size fits all. So there's no one hormone that is going to help and be tolerated by 100% of women, unfortunately. So with hormones, it's often a little bit of a trial and error to figure out what's going to work in terms of relieving a woman's pain, but also be manageable in terms of the side effects. I would say, in my experience, the Mirena is the most effective and the best tolerated. Because it tends to not have the major side effects of the other hormones, such as, affecting mood, causing headaches, bloating, weight gain, that type of thing.
Yeah, I love Mirenas. They're so good. Yeah. In terms of lifestyle, is there anything that people can do that you know of that has got a bit of evidence behind it?
Yeah, so when I manage my endometriosis patients, I always refer them to a dietitian. I think diet is hugely important in helping manage the symptoms of endometriosis. There's no cure for the disease, unfortunately, but trying to lower bodily inflammation can be really helpful. So a dietitian will look at a woman's diet and try and decrease the amount of pro-inflammatory foods in the diet. So things like processed foods, sometimes gluten, cow's milk, all the good things, right? Like caffeine, alcohol, that type of thing, are all foods that can worsen inflammation and endo symptoms. So foods that are good to introduce into the diet are anti-inflammatory foods. So cruciferous vegetables are good. Oily fish is good, that type of thing. But a dietitian can go through all those things. Naturopaths can sometimes be helpful in terms of other supplements to take, and that's a little bit beyond the scope of my knowledge, but I've had patients who find them really helpful. Acupuncture can be helpful. I've even heard recently of women doing hot and cold therapy to help decrease inflammation, and a couple patients have had success with that. So when we look at endometriosis, it's really trying to come at it from a lot of different angles to help get the symptoms under control.
And what about exercise? Whenever is that okay to exercise when you're having a lot of tummy cramps and things like that?
Exercise we think is good for endometriosis. Movement is good. Anything that is going to stretch muscles, core muscles, pelvic floor muscles is going to be helpful, right? So exercise in any form is good, but resistance training is good. Yoga is good. Those type of things are all really helpful.
And if we think about the endometriosis patient who's struggling with dyspareunia or painful sex, how would you approach that, Kelly?
Yep. So painful intercourse is it's a really big topic. I think in terms of endometriosis itself, the pain with intercourse due to endometriosis can get better with hormonal treatment or surgery, right? And so I would treat those things after sort of doing a full assessment of the woman's pain.
Okay. So, I think that I've asked all my questions on endometriosis. Is there anything that you think that might be helpful to add?
I think a lot of women want to know about surgery and endometriosis. When we do surgery, I have a lot of women come to me asking how often they should have a surgery and that type of thing. I think in general, surgery is one brief part in the management of what is considered a chronic disease, right? So endometriosis, right, in the long term needs to be managed with hormone treatment, lifestyle changes, diet changes, that type of thing. Surgery is often important to help get on top of symptoms, and some women will need repeat surgeries within a few years just to help get on top of their symptoms again. But we try to time the surgery so that women are not having laparoscopies, every year, every 2 years, that type of thing, because that puts the patient at risk. They can have scar tissue formation, that type of thing. So we'll try a lot of medical treatment. When that treatment is ineffective, or if a woman is wanting to try to conceive, then we'll arrange a laparoscopy to remove disease.
Okay. And I know that you do quite a lot of robotic surgeries. Is that in this realm, or is that separate?
Yeah, so robotics has been around for a couple of decades. On the Central Coast where I practice, we've had a robot available for 2 years now. And so I do use it for some of my patients with endometriosis. The benefit of the robot is that the optics are really fantastic. So the camera allows me to see endometriosis that I perhaps could not see with a general laparoscope. So really early disease, really superficial disease. And it also gives me really fine tools to do a really fine dissection, right? So I can do a very high quality surgery in terms of being able to remove all the endometriosis, peeling it away from organs and that type of thing. So I will often do robotic surgery on patients in whom I suspect more advanced disease, who have big cysts on their ovaries, that type of thing, where the robot's really going to benefit.
Okay, that's amazing. Okay, so I want to jump a little bit to dyspareunia generally. Yep. I look after a lot of perimenopausal, postmenopausal women, so I see a big group of women there who've got dyspareunia or painful intercourse. And then I often see women who've maybe just had a baby who are struggling with that as well. And then I also see some people who've actually never had a baby, not postmenopausal, really quite young, but really struggling and getting into a bit of a vicious circle of a lot of fear around having sex because it's hurt before. I'd love you to chat me through a little bit about what you would do with those patients.
Yeah, so we see a lot of patients for dyspareunia. I do by nature of being a gynecologist, and it actually is a really common problem that is not talked about, right? Sex should not be painful. It should be fun, right? And so if there is persistent pain with intercourse, then those women need to see their doctor or get a referral to a gynecologist. There are lots of different causes of painful intercourse. And so in a consultation, I will go through a patient's sexual history and try to go through a lot of symptoms to try to figure out where the problem may lie. And there may be one thing that's causing the pain, or there may be multiple things that are causing the pain that all need to be addressed. So we talk about dyspareunia sort of in two categories, so superficial and deep. So superficial dyspareunia is pain with initial penetration of the vagina. And so that can be due to changes in the vulvar skin. So sometimes a bit of dryness that can go along with genitourinary syndrome of menopause. It can sometimes be a bit of dryness in women who are breastfeeding and have just had a baby. There can be underlying skin disorders. So something called lichen sclerosis is quite common, but can cause the skin to not stretch appropriately and be quite sensitive. We can have conditions of the nerves that go to the vulvar skin, or scar tissue from childbirth, or that type of thing. And so those conditions are treated a specific way. Then there's also deep dyspareunia, which is pain with deeper penetration. And so causes of that can be things like endometriosis, can be adenomyosis of the uterus or other masses in the pelvis, or it can be pelvic floor tension or spasm, pelvic floor myalgia. And so when I examine, or when I interview women, I'll go through and try to get an idea of where the problem may lie. And then when I examine them, the examination is geared towards trying to figure out what the cause may be.
Yeah, okay. And so if you had someone, because I definitely see a lot of women with superficial dyspareunia, a lot, and I feel like there's obviously genuinely really a problem, but then they definitely become really quite scared of sex, and we end up with this sort of muscle spasm and lots of tension, and then they literally dread the whole thing.
Absolutely.
And then they nearly get in their own heads and freak out even at the thought of it. So how do you approach that and start to sort of break down all the issues that are going on rather than just the physical?
Yep. So what I will do is treat these women in a stepwise fashion. So I think obviously, if a woman is really anxious about intercourse, like you said, those vaginal and those pelvic floor muscles are going to tighten up. And so sometimes that can be a condition called vaginismus, or it can just be a bit of tension that then leads to pain. So if I think, based on the woman's history, that the problem started as a superficial problem, so either due to dryness, infection, that type of thing, I will treat that, right? So I might give these women a bit of estrogen for a time and see if that helps. I might treat this woman's infection. I might give them a medicine that modifies how the brain perceives pain. So something like an amitriptyline, that type of thing, and try to get that superficial pain under control. I'll then see them back after a couple months and assess their pelvic floor. And if their pelvic floor is still overactive or tight, or they're having difficulty with penetration, those women really benefit from seeing a pelvic floor physiotherapist. And so a lot of women think it sounds very odd to go see a physio for their pelvic pain. But that's what women's physios do, right? They assess the pelvic floor and they treat pelvic floor dysfunction. And so a pelvic floor physio will see a patient. She'll do a pelvic floor assessment and then teach a woman how to relax those muscles. So sometimes that can be with pelvic stretches, breathing exercises, sometimes what we call dilator therapy, where women will insert devices into their vagina in sort of a like a non-threatening, no-pressure way, if you will, to get the vagina used to accommodating an object, right? And then over time, there's some desensitization that then will hopefully help those women regain the ability to have intercourse.
One of my patients describes her vaginal dilators as the Russian dolls.
They are.
With increasingly getting bigger in size.
Yes.
Okay. So, and would you involve a psychologist in the treatment?
Yeah. So it depends on a woman's particular situation, right? There are sometimes relationship issues that are at play. And if that's the case, then a psychologist or a relationship issue can be of benefit. We're complicated creatures, right? We, in terms of intercourse, I think a woman with a young family often has an issue, or often can have trouble just focusing, right? Because our brain's going in a million different directions, trying to think of all the jobs that need to be done. And so those women might benefit from mindfulness in a certain way, and a psychologist in that way. So it all depends on sort of what we get to the root of is the cause of the trouble.
Yeah. Okay. And then do patients with dyspareunia ultimately end up having to have surgeries or anything?
Usually no. The odd woman who's got some scar tissue from childbirth or from a gynae surgery may need a surgical procedure to revise that scar tissue. But by and large, we actually try to stay away from surgery because it can actually make vaginal pain worse, right? So we try to treat it with more conservative things like medications and physio.
Mm. And just on, what about bleeding with sex? Is that ever normal?
So bleeding with sex can occur. It can occur for various reasons. Trauma, small tears and abrasions. If it is a persistent problem or if it's associated with pain, then a woman needs to see their doctor. Because occasionally it can be associated with abnormal anatomy. It can be associated with conditions of the cervix, such as infection or precancerous changes that then need to be evaluated.
Yeah. Okay, great. Okay, awesome. So let's again tack a little bit. Chronic pelvic pain, so not necessarily related to having sex, but just people who are having chronic pain in their pelvis. Tell me a little bit about that and what kind of patients that you would see with that.
So I get referred a fair few patients with chronic pelvic pain. And so those are women who have pain that is not just related to their periods or not just related to intercourse, but it can occur more days than not and has occurred for more than 6 months. And so these women are really debilitated often by their pain. I would say in women with chronic pelvic pain, there are often several causes of their pain. So they may have some underlying endometriosis. They often have a little bit of pelvic floor dysfunction, as in pelvic floor tension. Sometimes they have bladder or bowel issues that need to be addressed, like an irritable bladder, things like irritable bowel syndrome, sensitivities to diet, that type of thing. And so my appointments with these patients are fairly in-depth, trying to get to the bottom of their different types of pain. A lot of women will note that they have multiple types of pain and they can identify these pains, right? Trying to get to the bottom of the pains that are really bothersome to them, and then trying to talk about how best to treat them.
And so ultimately you're probably working in collaboration with like gastroenterology and things like that, are you?
Yeah, so we work with a big team. I remember a patient I saw a few years ago who came to me with chronic pelvic pain, and she had symptoms that were consistent with endometriosis, but also a condition that we call vulvodynia, which is pain to touch at the vulvar area. She had pelvic floor muscle dysfunction and then had some issues where her brain's response to pain was heightened. And so stimuli such as touch, which we normally wouldn't perceive as painful, her brain perceived as painful. And so she came to me and initially was really keen on having a laparoscopy to treat her endometriosis. We did a consultation. I talked to her all about her pain, and we talked about the fact that I thought that there were a lot of things contributing to the pain. She was not covered by a private health fund, and so was going to pay for her surgery to be done in the private. And I said, look, I really don't think that's what's going to be of benefit to you. I think that a better use of your finances would be to use this money to see a physiotherapist, use this money to see a pain clinic, and do these treatments and wait for surgery in the public system. And so she did that. She ultimately had her surgery for endometriosis, but actually was really, really good at going and pursuing all these other avenues of treatment. And she got better. So she was a really big success story, because these patients can be quite difficult to treat sometimes.
And what about the patient who's maybe had a chronic infection, like a chronic chlamydia or something like that? Do they have chronic pain, or?
They can, yeah. So they can as well. These women I'll try to treat with sometimes an extended course of a thrush medication if I think that thrush is the issue, or sometimes an extended course of antibiotics if you think that the pain's caused by chronic pelvic inflammation.
Okay. And in terms of how common it is, like, would you see someone every day with chronic pelvic pain, or is it?
I'd say I probably do.
Yeah. So it's quite a common issue.
It's very common.
Yeah,
very common.
What's prolapse?
Yep. So prolapse is also a common condition. And again, it's something that women don't talk about. They come to me and they're ashamed and they're embarrassed, but it's so common, right? So 1 out of 8 or 10 women will have prolapse. And so what pelvic organ prolapse is where the muscles and the connective tissue of the vagina weakens. And so the pelvic organs can then drop into the vaginal space and eventually drop out of the body. So the bladder can drop into the vaginal space, the uterus can come down, or the bowel can drop in. And I sort of liken it to turning a sock inside out. That's what's happening with prolapse. It's not a dangerous condition, which I think is important to explain to patients, but it's obviously a very distressing condition that then needs to be treated.
Yeah, absolutely. And it can be quite confronting for someone if they actually can see something that really just doesn't look right. The symptoms that patients would describe to me are like a heaviness or a dragging sensation.
Yes.
Is that what you would expect?
So that's very common. Women can have some element of bladder or bowel dysfunction, right? So if their anatomy is changed, women can sometimes have trouble passing urine, or they might have bladder frequency, and sometimes leakage of urine that may or may not be related to the prolapse. They can have bowel dysfunction, and so some women have great difficulty actually passing bowel motions, and it's quite common for a woman to actually need to use her fingers to help push to get stool out because of prolapse of the rectum.
Okay. I've definitely had a few patients with that. And so in terms of when do you know that you need to go and have a repair done, or what happens?
Yeah. So again, women need to see their doctor if this is impacting their life, or even if they just want a little bit more information about the condition. So we do a full assessment, sort of grade the prolapse and see where things are at, and then talk to them about treatment. So women in whom the prolapse is relatively mild, so not yet coming out of the vagina, can often get great relief of their symptoms simply by seeing a physio and working on the strength and tone of those pelvic floor muscles. Other women may need a little bit of vaginal estrogen, and then sometimes they need some support with a pessary, which is a little bit of silicone in various shapes that helps lift the pelvic organs back up. That's a really good option for many women because it's safe and reversible and has no downtime like surgery has.
Yeah.
Surgical repair is offered to women in whom these initial measures don't work, or in women in whom they just want surgery. And that can involve a bladder repair. It may involve a hysterectomy. It all depends on the anatomic issue. I think with prolapse surgery, what I try to enforce to my patients is that the surgery is not a guaranteed long-term fix. So it's similar to bariatric surgery or plastic surgery. You may get a result that is good for a short time. It may last for decades, but it may not. And there are women who then have recurrent prolapse that is then more difficult to treat.
I'd love to just talk through a little bit about anatomy, because there seems to be lots of confusion. Yeah. So the questions that I get asked all the time are, where's the vulva and where's the vagina, and what organs are taken away in a hysterectomy?
Yes.
So I think actually it's quite interesting because a lot of us, women and men, don't really even understand female anatomy. It's all just like, don't talk about it. So I would love you to explain which bits are which.
Yes.
If you didn't mind.
Yep. So the vulva is the actual outside of the vaginal area. So that encompasses the labia, which is at the opening to the vagina. It encompasses the clitoris. It encompasses the perineum, which is the area between the vagina and the anal opening. Just beneath that are the pelvic floor muscles that work to help support the pelvic pelvic organs and help maintain continence. And then the tube inside is the vagina, right? At the top of the vagina in women who have not had a hysterectomy, then is the cervix.
Yeah. Okay. And then whenever you have an abdominal hysterectomy versus a vaginal hysterectomy, what's happening there?
Yeah. So what a hysterectomy means in the medical profession is that we remove the uterus and often the cervix. We say a total hysterectomy, but a total hysterectomy does not necessarily mean removal of the ovaries. So a hysterectomy is where we remove the uterus and often the cervix. We'll often take the fallopian tubes at the same time because they're not needed anymore, and there's some evidence that they may increase the risk of ovarian cancer. Generally speaking, the vast majority of women retain their ovaries at the time of hysterectomy, so they won't go through menopause. And the ovaries remain because they're still producing hormone that helps with a woman's overall health and well-being. So it helps keep her bones healthy, her heart healthy, her mind healthy.
But isn't there some evidence to say that if you have a hysterectomy, that it potentially makes you have a slightly earlier menopause?
Potentially a year or so, but not dramatic.
Okay. I love that because I think there's so much confusion around the names of anatomy and people can't really explain where their issue is.
Yes.
And in terms of changes in that anatomy, so again, obviously both of us, but I see a lot of perimenopausal, postmenopausal women. There's definitely visual changes to that vulval area that happen in the postmenopause.
Yes.
What is it that looks different?
Yep. So women can have a bit of atrophy or shrinking of the tissues, right, because of lower estrogen. So the vulva can get a little bit, sometimes the opening can get a little bit more narrow. It can become a little bit more pale because of the lack of estrogen. And even the clitoris can shrink a little bit after menopause because of a lack of estrogen.
And in terms of using vaginal estrogen, do you feel like pessaries versus cream, or do you have a preference of what you like?
I don't have a preference. I just chat with a woman about what's more acceptable to them.
Yeah.
The idea behind vaginal estrogen is that it helps the lining of the vagina and the tissues of the vulvar area retain more moisture, right? So the cells become a little bit more plump, more stretchy, so able to stretch more to accommodate intercourse and that type of thing. And it also can change the balance of bacteria and the microbiome of the vagina. So it promotes a more healthy flora that help protect against UTIs and that type of thing.
And if you were to start vaginal estrogen, over what period of time would you expect to see an improvement?
Generally within a couple of months. It doesn't happen straight away, but within a couple of months, they should notice a bit of a difference.
Okay, awesome. And just to pivot again, cervical screening.
Yes.
So that has undergone a lot of changes over quite a short period of time. When I first moved to Australia 10 years ago, cervical screening was every 2 years, and then it's moved to every 5 years, and we've now even got self-collection. And cervical screening is definitely one of those real success stories of a screening campaign and a cancer reduction strategy. I'd love you to tell me a little bit more about that and why those changes have happened.
Yep. So Australia changed the screening program to screen for cervical cancer at the end of 2017. And so prior to this period, we were doing what we call a pap smear, which is where a doctor would brush a woman's cervix and we would look at that material under the microscope and look for any abnormalities. Now we have switched to testing for HPV, which is the human papillomavirus, and it is the virus that causes 99% of cervical cancers. So by screening for this virus, we try to identify women early who are at risk of developing cervical cancer. And it has allowed us to space out the screening interval, and we still are identifying 30% more women who have abnormalities. So it's been a really good story of success. The self-collect option is available now for women who are asymptomatic. And what we mean by that is they're not having any abnormal bleeding pattern, and women who would prefer to avoid a speculum exam. So that has a relatively high pickup rate for the virus as well.
Okay, awesome. Kelly, is there anything that you would love our listeners to know about female health or coming to see a gynecologist that maybe people don't know or seem to be a barrier?
Yeah, so I'll chat about a couple of things, both as an obstetrician and a gynecologist. So I think so I do about 50-50, right? 50% obstetrics, 50% gynecology. And as an obstetrician, I think it's really important, and I think what we do as obstetricians is look out not just for the health of the mother and baby at the time of pregnancy, but throughout the health of a woman over her whole reproductive lifespan, right? And so the way that a woman is treated around the time of her pregnancy and birth, and the way that her birth goes can have massive implications for her emotional health, for her physical health, and for her relationship, really. And so one of the things I really love about my job as an obstetrician is to try to advocate for women around that birth time, but also around her entire reproductive life. As a gynecologist, I then assess and treat any other issues that are related to reproduction, bleeding, fertility, bladder issues, sexual function issues, and menopause. When women come to see a gynecologist, I think many women are not quite sure what to expect. I would encourage them to try to do a couple of things beforehand. So trying to keep a diary of any symptoms they may have is really helpful, especially in regards to how it relates to their menstrual cycle. And trying to track their menstrual cycle is really helpful. They don't really need to do any physical preparation for an appointment. Generally, if they're on their period when they come, it's not a big deal unless they need a procedure where I have a close look at their cervix. They don't need to do any personal grooming, right? We don't care about that at all. It doesn't affect anything that we do.
And yet women always feel the need to apologize.
They do. They always feel the need to apologize. This is not a date. It's a medical exam, right? It doesn't matter to me one way or another. I'm there to help them and help fix whatever concern that they have. So during the appointment, I often ask very intimate questions and very personal questions. And so I think that's important that they be prepared for that, especially if they're considering who they might bring to that appointment with them if they bring somebody. And I always encourage my patients to ask whatever questions they want. Nothing is off the table. Nothing is off topic. I'm always happy for patients to do their research ahead of time. And I'm actually really happy when they do that because it gives me a chance to build on whatever information they have and to clarify any questions that they may have as well.
Good, I agree. My patients always apologize. I'm sorry I Googled it. And I'm like, don't be sorry. Don't be sorry. I'm glad you made it.
Right? Yeah, exactly.
You're already coming with some baseline knowledge, which is great.
Yes.
Okay, you have been amazing. Thank you so much for letting me pick your brain. So if anyone listening wanted to come and see you, how could they do that?
Yep. So I work in the public system, but I also work in private practice. So they can look at my website for contact information. So it's www.drkellyhankins.com.au, and that will have the contact information for my rooms. So they just need a GP referral, and I'm happy to see them.
Amazing. So my final question, which we ask all of our guests, is if you could give the 20-something-year-old Kelly a piece of advice, what would you tell her?
There's a lot of things, and that could be getting pretty deep, I think. But I would say probably a really important piece of advice is to always keep an open mind and always keep learning. I think when I was in my 20s and my late 20s and I had just finished my training, I was pre-children, I sort of thought I knew it all, and I thought I knew how my life would look. And I've been humbled continuously along the way. I think you can always learn from your colleagues. You can learn from people in other specialties. I learn heaps from my GP colleagues. I learn a lot from my patients. They teach me something new every day. And I learn heaps from my children, right, who are continually humbling me. So I think, just keeping an open mind and always being open to learn is a great way to grow, be the best you can be, and try to maintain your youth as well.
Amazing. Kelly, thank you so much. It's been amazing. I really believe our listeners will have benefited so much, and I'm sure everyone has got a nugget or two of really helpful info.
Good. Thank you so much for having me. It's been fun.
If you enjoyed this episode, I'd really love you to leave a review or share with someone who you believe would benefit from hearing this conversation. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.